All right, and welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Today's topic will be another episode in our vasopressor and inotrope series. Particularly today we'll be talking about dobutamine, one of the very common inotropes. We'll be going through the mechanism of action of dobutamine, the receptors it works on, dosing and titration of dobutamine, how to monitor it, hemodynamic effects, the summary of those effects, indications for dobutamine, contraindications, precautions, adverse effects, some interesting pharmacogenomic considerations. We'll compare dobutamine to other inotropes, talk about some clinical pearls, and then we'll end actually with a couple practice questions. This is a new addition to some of these episodes where we go through some practice questions at the end. So let us know what you guys think of that, if that's helpful or not. And I think that's all I'll have for you today on dobutamine. For those new to the channel, this is Whiteboard Medicine. All of these study guides, as well as more practice questions, are available on our Patreon page, linked in the episode description. We also have a free weekly newsletter that focuses mostly on public health and emerging infectious disease. Then we have a YouTube and podcast platform. We'd love for you to check out any and all of those, subscribe, follow along, all that good jazz. And then last friendly reminder, none of this is intended to be acted upon as medical advice. Please stick around to the end of the episode for the full disclaimer. We appreciate y'all. Let's dive into dobutamine. Mechanism of action. How does dobutamine work? Well, dobutamine is a synthetic catecholamine, right? Catecholamines are things like norepinephrine, epinephrine, even phenylephrine are all different catecholamines. They act on catecholamine receptors. They're also sometimes called adrenergic. These are all somewhat synonyms, okay? Dobutamine in particular, though, focuses mostly on beta receptors, okay? Beta-1 adrenergic receptors. These receptors are in the heart tissue itself, right? And we have the heart, and they have these beta-1 receptors. Dobutamine stimulates those beta-1 receptors, and it increases myocardial contractility. It's a positive inotrope, positive inotropy. Inotrope being increasing contractility. It also somewhat increases heart rate. Heart rate increases are known as chronotropy. So inotropy is contractility. Chronotropy is heart rate. So beta-1 receptor agonism, stimulating beta-1 receptors in the heart, dobutamine increases myocardial contractility, also known as inotropy, and it increases heart rate, also known as chronotropy, although the primary effect is this increase on myocardial contractility. Dobutamine does have some slight beta-2 adrenergic effects. Beta-2 actually works on peripheral blood vessels. Let us mute our computer here, sorry. These peripheral blood vessels have all these smooth muscles coating the outside of them. And there's alpha-1 receptors in these. Alpha-1 receptors cause vasoconstriction, but there's also beta-2 receptors. And beta-2 receptors actually cause vasodilation. So dobutamine affects beta-1 receptors in the heart, increasing myocardial contractility, positive inotrope, and increasing heart rate, positive chronotrope. It also, though, stimulates beta-2 adrenergic receptors in the peripheral vasculature, which causes some mild vasodilation. This is why dobutamine can decrease blood pressure and cause hypotension sometimes. It gets confusing because there's some slight alpha-1 agonism. This is dose dependent, and typically the beta-2 effects are more. So although there is some slight alpha-1 agonism, which could cause vasoconstriction, the beta-2, we wrote beta-1, the beta-2 effects on the peripheral vasculature are more. So there's usually more vasodilation. So dobutamine increases heart rate, increases contractility, and decreases blood pressure. When it comes to receptor sensitivity, there's some ratios here just to help you understand how much effect there is. And the ratio is 5 to 1 to 0.5, and that's for beta-1 to beta-2 to alpha-1. So there's 5 times as much beta-1 activity as beta-2 activity. And then there's 2 times as much beta-2 activity as alpha-1 activity, which is why you get contractility mostly from beta-1, increased heart rate from beta-1, some peripheral vasodilation from beta-2, and then alpha-1 is not really efficacious because it's such a small percent of effect that the beta-2 effect being higher causes vasodilation rather than the alpha-1 causing vasoconstriction. Hopefully that makes sense. It's a little confusing, so let us know if you have questions in the comments, but it's really about receptor selectivity and sensitivity, kind of that potency, and it most potently affects beta-1. Next potency affects beta-2, and then there's just a slight amount of effect on alpha-1. Stereochemistry, this is not that important unless you really want to go down the rabbit hole, but dobutamine is actually a racemic mixture. Racemic mixtures are outside the content of this video, but there's a negative and positive isomer. That's the racemic mixture. It's a mix of those two. And depending on the isomer, there's different potencies of effects on different receptors. So the positive isomer primarily affects beta-1 and beta-2 receptors, and then the negative isomer primarily affects alpha-1 receptors. And you can see negative isomer, alpha-1 agonist, weak beta-1 antagonist, right? So there's antagonist and agonist. Agonist means it stimulates the receptor, antagonist means it inhibits it. The positive isomer is a beta-1 and beta-2 agonist and alpha-1 antagonist. All this is confusing and probably not needed in terms of putting it in your brain. The thing to remember is that beta-1 receptor effect is more than beta-2 receptor effect, which is more than alpha-1 receptor effect. All right? And just know there's different isomers that kind of do different things within the mix of dobutamine. Dosing and titration. So in patients, the initial dose of dobutamine is usually 2 to 5 micrograms per kilogram per minute, with a common range being 2 to 15 micrograms per kilogram per minute. We don't tend to go above 15 micrograms per kilogram per minute, but you can. Some people do go up to 20. But if you were to see someone on 15, certainly 20 micrograms per kilogram per minute of dobutamine, that would be a really high dose. All right, it usually starts somewhere around 2. The onset of action is 1 to 2 minutes. It starts to act really quick. The duration of action is very short. The effect stops within about 10 minutes of discontinuation, so fast on, fast off. And then the metabolism, it is metabolized in the liver. It uses COMT to convert it to an inactive metabolite. And then those inactive metabolites are renally excreted. But the metabolites renally excreted are inactive. So renal function does not necessarily drive how much active dobutamine there is. Rather, these enzymes in the liver break dobutamine down into its inactive form that then is renally excreted. So dobutamine is fairly safe to use in patients with renal dysfunction because it's already kind of broken down into its inactive form before it has to be renally excreted. When you monitor dobutamine use and you titrate it, it's more complex than titrating something like norepinephrine in shock, right? Norepinephrine is something like septic shock. You're just titrating it to your MAP goal. Mostly that MAP goal is 65 millimeters of mercury, right? You haven't met that MAP goal. Every 2 to 5 minutes, you go up on the norepinephrine until you reach that MAP goal. But dobutamine is a lot harder because dobutamine is an inotrope. And what you're trying to do with dobutamine is you're trying to increase cardiac output, and by doing so, improve organ perfusion. Right? Because that's the whole goal. This is not to increase the blood pressure. The blood pressure actually usually drops while you're on dobutamine because of that beta-2 effect causing vasodilation. So the whole point of this is you're trying to increase cardiac output to increase organ perfusion. And to understand if you're doing that, you can trend a lot of different things, right? One of them is the mixed venous oxygen saturation, sometimes the lactate. Sometimes you look at CVP, MAP. There's also kind of advanced hemodynamics like thermodilutions and fix and all that kind of stuff. This is all outside the scope of this lecture, but the key is to know that titration of dobutamine is more complex than titration of something like norepinephrine because you're not going for blood pressure goals. It's not a vasopressor that you're using to increase the blood pressure. It's an inotrope. You're using it to improve your cardiac output with the goal being to improve organ perfusion. All right, hemodynamic effect summary. So what does dobutamine do to your hemodynamics? Well, we know that it does increase your heart rate, it increases your contractility, and by doing so, it increases your cardiac output. As we know, cardiac output equals stroke volume times heart rate. So if you're increasing the heart rate and you're increasing the stroke volume through an increase in contractility, you're going to be increasing your cardiac output. Your systemic vascular resistance, it often decreases. That is that beta-2 effect causing vasodilation. Your MAP, it can often decrease as well. Same thing, beta-2 effect causing peripheral vasodilation. So it can decrease your SVR and decrease your MAP. This is more advanced stuff, but your PA pressures can sometimes decrease. That's your pulmonary artery pressures from vasodilation. Your pulmonary capillary wedge pressure often decreases because you have improvement in forward flow, and your coronary perfusion, how well you're getting blood flow to your heart, often improves because of increased diastolic time and cardiac output. The caveat here, though, is that also dobutamine increases your myocardial oxygen demand because you're asking that heart muscle to squeeze more robustly. And when you ask it to squeeze more robustly, it consumes oxygen. So it needs more oxygen delivered to the myocardial tissue while you're on dobutamine, which dobutamine helps do, but where you fall in that balance is tough to say, right? Does the amount of contractility you're making that heart muscle do on dobutamine outpace the increase in blood flow you've triggered to the myocardial tissue? Tough to say. So sometimes you can get myocardial ischemia or worsening myocardial hypoxia. There's not enough oxygen being delivered for how much work you're making that myocardium do. But sometimes you're okay. Sometimes you're kind of balanced out in that regard. All right, indications for dobutamine. The biggest one is cardiogenic shock, right? It's first, second, third, fourth. We talk about it in different ways. Cardiogenic shock, low output heart failure, right ventricular failure, pulmonary hypertension. Now, sepsis-induced cardiomyopathy, sometimes abbreviated SICM, sometimes abbreviated SCCM, is this sepsis-induced myocardial dysfunction. These are patients who have sepsis who sometimes get depression of their contractility and myocardial function, leading to low cardiac output. And there's no good evidence to drive this, but sometimes an inotrope like dobutamine that may increase their cardiac output, even if they're in septic shock, may be helpful. Patients who are awaiting something like a left ventricular assist device or a transplant sometimes need an inotrope. Milrinone is commonly done at home. Sometimes dobutamine can be too. These are really sick patients, though, and this is, kind of outside of the specter of the critical care nature of this lecture. That's more kind of outpatient therapies. Sometimes you can give it for stress echocardiography to stress the heart, to try to diagnose a patient with some type of coronary ischemia. And then in patients who are vasodilatory, they're in distributive shock, you have to be really careful with this. So if a patient is septic, you don't just want to start them on dobutamine to increase their cardiac output, because this will actually decrease their blood pressure in their MAP. Most of these patients need norepinephrine to increase their MAP, and then if they have low cardiac output because they have something like sepsis-induced cardiomyopathy, you can sometimes give them dobutamine as an adjunct to try to increase that cardiac output. All right, contraindications and precautions. In patients with really bad hypertrophic obstructive cardiomyopathy or idiopathic hypertrophic subaortic stenosis, IHSS, these are conditions where you need as much filling time as possible. Okay, you don't want that heart squeezing too hard or too fast because they have this dynamic obstruction of their outflow tract. Again, this is complex. If this isn't registering, just ignore it. But for those kind of down the road who have a little bit more advanced knowledge of this, this is like dynamic outflow tract obstruction, where you want to be really careful with inotropes because putting the patient on an inotrope that's going to increase their heart rate and increase their contractility can sometimes worsen this outflow tract obstruction where you can't get blood to pump out of the left ventricle through the aortic outflow tract and out the aorta to the body. All right, and obviously if you have a known allergy, you don't want to use dobutamine. Use with caution. Patients with severe hypotension, use with caution because it will drop the blood pressure more. Patients with significant ventricular arrhythmias, you have to use with caution because of all the beta-1 effect. Beta-1 effects increase risk of tachydysrhythmias. All right, so using caution in them. Those with active myocardial ischemia, as we said, this can sometimes increase myocardial oxygen demand. So if you have someone with active myocardial ischemia, giving them dobutamine, you might have to, right? You might have to give it to them to help them survive, but it will worsen their myocardial ischemia because you're asking that muscle to work in overtime, and it increases that muscle's oxygen demand, and they might not always get enough blood flow to satisfy that oxygen demand. All right, and then persistent tachycardia and atrial arrhythmia, similar to ventricular arrhythmias that we talked about above. Adverse effects of dobutamine, as can be kind of surmised from what we were just talking about. Dobutamine can cause tachyarrhythmias. It's through that beta-1 mediated effect that increases inotropy and chronotropy, or heart rate. And this is one of the big barriers. Sometimes you have these really tough cases where patients in cardiogenic shock, they need an inotrope like dobutamine to increase their cardiac output to perfuse the rest of their bodies, but they're going in and out of ventricular arrhythmias. And the dobutamine is exacerbating those arrhythmias, but you also need it. So sometimes you got to do antiarrhythmics like amiodarone or lidocaine or all these things to try to temporize and decrease the arrhythmias while continuing the dobutamine. Sometimes you need to dose reduce the dobutamine and kind of hit a happy medium. But this can be a really, really tough patient to manage. As we said, dobutamine has beta-2 receptor effects, which causes vasodilation, so it can cause hypotension, especially if someone's volume deplete or vasoplegic. It causes myocardial ischemia because it increases myocardial oxygen demand due to that beta effect. You can get tachyphylaxis, so over time, the beta receptors it acts on downregulate so that it's not as effective, and this usually is within 48 or 72 hours of a continuous infusion. So once you get to day 2 or 3 of being on dobutamine, you sometimes get lower effect from it because the heart downregulates all those beta receptors, and this is known as tachyphylaxis. So if you see a patient needing higher and higher doses after 2 to 3 days, sometimes it's just because they're not as responsive to it anymore. And then this is rare, but eosinophilic myocarditis. This is with prolonged dobutamine use. It's really only case reports, but if you get eosinophilia or high eosinophils and worsening cardiac function, sometimes it can be because this eosinophilic myocarditis, but this is really prolonged use. This is not something you're just going to see in a couple days in the ICU. There is a pharmacogenomic consideration, and this is just something we wanted to mention, is that some people have genetic polymorphisms in receptors responsible for beta effects, and as such, sometimes they will not respond to dobutamine the same way someone else will. So if you have someone with a really odd response to dobutamine, they might have one of these polymorphisms. They're not common. We don't test for them in the clinical arena very much. But if you're thinking about like inotropic therapy in the outpatient setting at home, sometimes this is good to know about. Dobutamine versus other inotropes. We have talked about all these inotropes in different videos, so check those out if you want to hear about them. But there's going to be dobutamine versus milrinone versus epinephrine versus dopamine versus a medication called levosimendan, which is actually not FDA approved in America, but it is approved in some other places. So mechanism of action, dobutamine is a catecholaminergic or adrenergic inotrope. Beta-1 effects are the most, causing increased contractility, followed by beta-2 effects, which cause vasodilation. Milrinone is a PDE3 inhibitor, phosphodiesterase 3 inhibitor, so it's non-catecholaminergic. Epinephrine is a vasopressor with alpha-1 effects causing vasoconstriction, but it also has beta-1 and beta-2 effects too, so there is some inotropic. Dobutamine is not consistently used anymore. It sometimes is used for bradycardia, but not much, so we're going to just ignore that one. And then levosimendan is actually a calcium sensitizer, which is so interesting. It causes the myocardial cells to be more sensitive to calcium, and when they get that calcium, it causes the muscle to constrict. So it works different than the other two as well. Dobutamine has a rapid onset and short half-life. It's good for cardiogenic shock. Milrinone has less chronotropy, so it's less heart rate effective. It does not increase the heart rate much. And milrinone is really nice for RV failure because it causes some more pulmonary vasodilation, which can offload that right ventricle. Epinephrine is good for vasopressor N inotrope. It causes increase in blood pressure and also increase in contractility. So just some of the differences there. If we get to the clinical pearls, you may prefer dobutamine over milrinone, which is the other most common inotrope in heart failure with hypotension, since milrinone actually causes more vasodilation and hypotension, although certainly dobutamine will cause hypotension. In septic shock with myocardial dysfunction, dobutamine can help augment cardiac output, especially after volume is optimized. So that's that sepsis-induced cardiomyopathy. Dobutamine can sometimes be a nice drug to increase the cardiac output. If you're using a balloon pump or Impella, dobutamine may synergize by unloading the ventricle while enhancing contractility. This is more advanced concept. Pulmonary artery catheters, also known as Swan-Ganz catheters, are helpful in titrating dobutamine. And then when you wean dobutamine, you usually reduce it by 1 to 2 micrograms per kilogram per minute every 30 to 60 minutes while monitoring those perfusion markers. All right, let's get into some practice questions. We haven't done this in a video before, or an episode if you're listening to this in podcast form. So we divided them up into a beginner question, an intermediate, and an advanced. And those watching this on YouTube, we think we just showed you the answer to the first one. Apologies. So the beginner question: what is the primary hemodynamic effect of dobutamine? A, decreases heart rate and blood pressure. B, increases contractility and cardiac output. C, causes profound vasoconstriction. Or D, increases preload by expanding volume. What is the primary hemodynamic effect of dobutamine? And we're just going to go straight into the answers. So if you want time to think, just pause the episode and think, and then restart it, because we're just going to dive right into the answers. So answer is B, increases contractility and cardiac output. All right, so dobutamine primarily stimulates beta-1 receptors, and beta-1 receptors work in the heart by increasing myocardial contractility, which increases the stroke volume and leads to an increase in cardiac output. It does not cause vasoconstriction. It does not volume expand. It actually causes vasodilation. So B is the correct answer, by increasing contractility and cardiac output. All right, into the intermediate level question. A 70-year-old patient with systolic heart failure with an ejection fraction of 25% is started on dobutamine for acute decompensated heart failure with cardiogenic shock. Over the next hour, her MAP drops from 72 to 63 millimeters of mercury despite improved urine output and increased cardiac index. What is the most likely explanation? A, dobutamine had a delayed onset of action. B, dobutamine causes vasodilation through beta-2 stimulation. C, dobutamine leads to increased afterload. And D, dobutamine worsens left ventricular function. Going right into the answer, so pause here if you want. The answer is B, dobutamine causes vasodilation through beta-1 stimulation. So dobutamine has some beta-2 agonist activity. Beta-2 affects the peripheral blood vessels and causes mild vasodilation, which can lead to a drop in systemic vascular resistance and MAP, especially in volume-depleted patients. Milrinone is even more robust in causing vasodilation, but dobutamine does too, right? So the correct answer is B, dobutamine causes vasodilation through beta-2 stimulation. And then last question is the advanced level. A 68-year-old man in cardiogenic shock is started on dobutamine at 5 micrograms per kilogram per minute. He is also receiving carvedilol for chronic heart failure with reduced ejection fraction. Despite escalating dobutamine doses, his cardiac index remains low. Which of the following best explains this blunted response? A, upregulation of PDE3 activity due to beta blockade. B, beta-2 receptor desensitization. C, competitive inhibition of beta-1 receptors by carvedilol. Or D, reflex vasoconstriction via alpha-1 stimulation. Going into the answer, so pause if you want. Answer is C, competitive inhibition at beta-1 receptors by carvedilol. So dobutamine works through beta-1 receptor agonism. And in patients on chronic beta blocker therapy, this can actually be blunted, especially patients on non-selective beta blockers like carvedilol. These block both beta-1 and beta-2 receptors and can lead to dobutamine having a more blunted response. So that's all we have for you today. Hopefully you learned something. Let us know what thoughts, comments, questions you have down below. Again, check out our Patreon page for this study guide as well as additional practice questions, free weekly newsletter, podcast, YouTube, all that good stuff. Subscribe, hit the bell button, follow along, and either way, stay well, keep learning. We'll see you next time. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.